Okay, hello everybody. I hope you are excited to join us today. I would like to welcome all of the attendees and our distinguished panelists to the fourth and final webinar in our series on legal preparedness for public health law emergencies. We had three great webinars before this final one. We had a presentation on on hurricanes and high water incidents like flooding. We had a great webinar on the Emergency Management Assistance Compact. We had a great webinar on Ebola and disease investigation authorities in the United States. And our final webinar is this one today, entitled Information Sharing 101, Protecting Public Health Data. This webinar, as with the previous webinars, is put on by CDC's Center for Preparedness and Response and Public Health Law Program in collaboration with the National Governors Association and the American Bar Association. My name is Gregory Sunshine, and I serve as a public health analyst on emergency preparedness issues in CDC's Public Health Law Program. I am very pleased to serve as the moderator for today's webinar. Today's webinar, as I mentioned, is the last in a series of 4 organized to focus on preparedness and response for public health emergencies. We wanted to let you know that the recording of the past 3 webinars in this series can be viewed at nga.org. That's NGA as in National Governors Association.org/webinars. This 90-minute session will be led by 2 wonderful speakers who are experts on public health data release and privacy protections. Our speakers will provide an overview of the legal authorities to collect, use, share, and protect health information in a public health emergency. Our first and third speaker, Kaysen, will discuss HIPAA, the Health Insurance Portability and Accountability Act. Our second speaker, Rachel, will discuss state disease investigation authorities and privacy protections. And then we'll turn it back over to Kaysen, who's going to close us out to discuss ethical considerations in data sharing. So we're really fortunate to have an excellent panel of speakers with us today. And after briefly introducing them, I'll turn the mic over and we'll get started on the substance of our program. I will introduce each speaker and they will provide their remarks. And then I'll take control back and do the Q&A portion of our webinar. But as a reminder, folks, if you have questions for our esteemed panel, please enter them into the Q&A box and we'll get to those questions at the end. We should have at least 20 or 30 minutes, plenty of time for Q&A unless things get out of control. But as moderator, I will promise I won't let that happen. So, Kaysen Schmidt, our first and third speaker, is an assistant professor at the Department of Health Policy and Management at the Texas A&M School of Public Health, where he actively researches the role of law in the promotion of health information technology, including health information exchanges and telehealth. He is actively studying the ethics and impact associated with federal and state laws protecting privacy and confidentiality in the age of big data. In addition, he's working on a number of really interesting data sharing projects, including developing an Apple Watch mobile app to detect mental health episodes among college students to facilitate immediate intervention, and developing a global data repository of astronaut health information to understand the health effects of space travel. So pretty neat, and if you have questions about those, please don't feel like you're restricted in the Q&A portion to only the things discussed in this webinar. Feel free to bring those up. Prior to joining Texas A&M University, he worked for the U.S. Centers for Disease Control and Prevention in the Public Health Law Program, a colleague of Rachel and mine, as a legal fellow and a contractor to promote the use of law as a tool to promote public health and data sharing. He's a member of the State Bar of Arizona and earned his JD from the Sandra Day O'Connor College of Law at Arizona State University. Our second speaker is Rachel Holkauer. Rachel Holkauer serves as a public health analyst through Cherokee Nation Assurance with the Centers for Disease Control and Prevention's Public Health Law Program in Atlanta, Georgia. Rachel specializes in work to improve public health through the development of legal tools for and the provision of technical assistance to state, tribal, local, and territorial governments, as well as public health officials at the Centers for Disease Control and Prevention. She's the lead researcher for PHLP's Health Information and Public Health Surveillance portfolio. Rachel received her MSPH from the University of North Carolina Gilling School of Public Health and her JD from Georgia State University College of Law. And with that, I'm going to turn things over to Kaysen, and all bear with me as we have this handoff. I think all should go well. Okay. And And Kaysen, you should.
All right. Thank you very much, Greg, and all for having me on this webinar. I'm very honored and appreciate the opportunity to speak with everyone today. So I thought I'd start us off with what is usually the elephant in the room, the single biggest issue that comes up when you're talking about trying to leverage health data to respond to an emergency. Chances are that you've been in a situation where somebody has said, nope, we can't do that, HIPAA won't let us do that. And so I thought that before we start really diving into some of the issues today, especially the state law issues, we'd try to dispel some of the misconceptions that revolve around HIPAA. So we're going to start off by talking about, let's see if I can advance the slide here. There we go. I'm going to provide an overview of some basic concepts of HIPAA to help you understand how the law works. And I'm going to try to gear a lot of the discussion specifically to emergencies. But if you take only one thing away from this brief segment on HIPAA, it's that HIPAA is generally very friendly to public health activities. And so anytime you're in a situation and you are doing a public health activity that requires access to health information that's protected under HIPAA, and somebody is telling you, no, HIPAA won't let us do that, you should have some healthy skepticism of that. And that's a great time to try to involve your organization's legal counsel to investigate not only what the law is actually prohibiting, but whether or not there are also some tools and provisions within HIPAA that would allow you to use that data, obtain that data for the public health purpose. Because generally, HIPAA does have a lot of provisions that allow public health authorities to use data for these types of purposes. I'd also like to point you all to some guidance that came out in late 2014, and this was inspired in part by the Ebola situation, and it was a bulletin released by HHS that talks about HIPAA specifically in the context of emergency situations. And a lot of what I'm talking about today is packed into that bulletin. So, if there's one great resource for you to look at to answer most, if not all, of your questions related to HIPAA and emergencies, it's going to be that guidance from 2014. And the hyperlink is right there, and I think we can maybe give that hyperlink out in the chat box later as well. Okay, so HIPAA basics. HIPAA applies only to covered entities and the business associates of covered entities. Now, a covered entity falls into three boxes. They're either healthcare providers, health plans, or healthcare clearinghouses. You notice that health departments or health authorities, public health authorities, are not in that list. If a public health authority or a health department does any of these three functions, it may still be in whole or in part covered by HIPAA. But public health in its pure form is not a covered function under HIPAA. So a public health authority that isn't declaring itself as covered under these three covered entity categories is not subject to HIPAA. They may be subject to other federal or state laws, but they are not covered under HIPAA if they're not doing have not declared themselves as doing one of these three things. Business associates are organizations that aren't necessarily covered entities themselves, but they are doing things on behalf of or providing services to a covered entity. Some good examples of that are a health information exchange or health information organization that helps pass and share information from one healthcare provider to another. That's a common example of a business associate. E-prescribing gateways are another example of a business associate. And these business associates are subject to the HIPAA rules. The next basic aspect of HIPAA that you need to understand is HIPAA only applies to protected health information. Protected health information is essentially information that is individually identifiable and pertains to the health of that individual. And importantly, it's either created or received by a covered entity, right? So if you are not a covered entity and you have identifiable health information, you're still not subject to HIPAA, right? So that's something really to keep in mind, that it's protected health information that is either created or received by a covered entity. But just because you have protected health information, HIPAA has provisions that allow you to de-identify that health information. And once it's been de-identified under the standards that are within the HIPAA law, it's no longer subject to the restrictions and the rules of HIPAA. So de-identified information can be shared or used for various purposes. The next basic is the general rule of HIPAA, and the general rule of HIPAA is one of non-disclosure, right? So you may not, or a covered entity or a business associate may not use or disclose protected health information unless it's permitted under the HIPAA law. And there are a lot of permitted purposes in HIPAA. There are many permitted purposes, and there are also a number of exceptions as well. So the three main ones are listed here, but this list is not exclusive. So you are allowed to, if you are a covered entity, you may use or disclose health information to the individual. You may use and disclose health information for treatment, payment, or healthcare operations. And if you've got the authorization of the individual, you can pretty much use or disclose that health information for any number of purposes. Now, of course, this is a bit of an oversimplification. There are some restrictions here, but this gives you the general outline of what HIPAA permits. But this is the basic rule, right? So essentially, you cannot disclose it if you're a business associate or a covered entity, and unless it's one of these purposes or unless you've got the authorization of the individual. Except there are a ton of disclosure exceptions and use exceptions to HIPAA. These are uses and disclosures that do not require the authorization of the individual, right? And the biggest one here is for public health activities. So if you've got a public health authority that is authorized by law to collect or receive this type of health information, then you can disclose that as a covered entity. You can disclose that protected health information fully identifiably to that public health authority under this exception. The HIPAA also allows for cooperation between a public health authority and a foreign government agency. And this allows for inter-jurisdictional sharing in response for some type of public health response. And you see there in the second bullet that it has to be at the direction of the public health authority. So this isn't just some healthcare providers sharing protected health information willy-nilly with a foreign government under this exception. It has to be at the direction of the public health authority. Covered entities can also disclose information to persons at risk of either contracting or spreading a disease or condition, right? So this allows the covered entity to act to limit the spread of disease. Nope, I'm jumping ahead, sorry. All right, so there are also exceptions within HIPAA that permit disclosures to family, friends, and others involved in individuals' care, and for notification. So this is a somewhat broad set of exceptions, but here's some examples. So if there are individuals that are involved with the patient's care and are helping out with the decision making for that care, then those types of disclosures, unless objected to by the individual, are permitted. There are disclosures if they're necessary to identify or locate and notify family. HIPAA permits certain disclosures to disaster relief organizations like the American Red Cross for the purposes of coordinating notification of family and other persons involved in the patient's care, the patient's location, general condition, or death. So, again, these are not without restrictions and conditions, but these are the types of examples that, under certain circumstances, covered entities are permitted to do under the HIPAA rules. And just to finish up, you are allowed as a covered entity to disclose or use protected health information as necessary to prevent or lessen a serious and imminent threat to the health and safety of a person or public. So again, this gives you quite a bit of leeway to use health information to prevent some danger from happening. Also, HIPAA permits, there's a very broad exception, any disuse or any disclosure that is required by law. And so if your state has a law that requires certain disclosures of health information, HIPAA permits that. And there are many other exceptions. But again, the key takeaway here is that HIPAA is generally very, very friendly to public health activities. So you should always be very skeptical of any time somebody is saying, no, HIPAA doesn't allow us to do this for this purpose. That's a great time to check in with your counsel and making sure that HIPAA does in fact prevent that, or that there are, whether or not there are certain provisions or tools within the HIPAA framework that give you the authority to use or disclose this information. So with that very fast primer of HIPAA, I will hand things off to Rachel.
Great, thanks, Kaysen. That was a great introduction to some of the public health activities that I'm going to talk about now for a little bit. I'm going to talk about privacy and confidentiality considerations in state law, but related to public health investigations, which is one of the major public health activities that Kaysen mentioned as a major exception to the HIPAA privacy rule. So I don't think I have control, Greg. Great. There we go. Of course, because I'm a lawyer, I have to start off with a disclaimer. This presentation is for educational purposes only and does not constitute legal advice. We often say around here that I am a lawyer, but I'm not your lawyer. So if you do need legal advice, again, I encourage you to consult an attorney within your own organization. Okay, so once again, we're going to spend some time talking about public health investigations and where privacy and confidentiality considerations arise within the context of state law. Just a brief overview. We're going to talk quickly about disease surveillance and reporting and how it's conducted in the United States, just to set the background, and then describe the legal authorities for conducting disease investigation, and then I'll get into the privacy protections, exceptions, and waivers. Okay, so first, disease surveillance and reporting. Disease reporting in the US in the public health system, there's sort of two primary disease surveillance systems. So first, there's the National Notifiable Disease Surveillance System, which enables all levels of government to voluntarily share disease-related information with the federal government. This system sometimes is misconstrued as being a mandatory reporting system, but the federal government does not, in fact, have the authority to mandate disease reporting, except at ports of entry. So, you know, the federal public health use of this information is to monitor, control, and prevent occurrences and spread of state reportable diseases, and to sort of provide support to state, tribes, territories, and local governments that are dealing with infectious and non-infectious diseases. In addition, there are, you know, states and localities can and in fact do all require healthcare facilities, healthcare providers, and laboratories to report particular infectious and non-infectious diseases to the state or local health department. As I said, all states and actually some localities require providers, facilities, and laboratories to report suspected or confirmed diseases. And the diseases that are considered reportable and the methods for reporting those diseases are determined by each jurisdiction's law. So here are just a few examples of state disease reporting requirements and how particular jurisdictions go about creating those lists. So some jurisdictions require reporting for specific diseases such as Ebola or tuberculosis, Zika, or West Nile. And then there is some required reporting for any illnesses that fall within a class of diseases such as viral hemorrhagic fevers, arboviruses, and severe acute respiratory syndromes. And finally, jurisdictions may require reporting using a sort of public health importance or other dangerous diseases catch-all sort of phrasing. For example, you know, any dangerous, contagious, or infectious disease, or any cluster of illnesses. And we see this a lot, any unexpected pattern of cases, suspected cases, deaths, or increased incidences of diseases of major public health concern. Again, because disease reporting requirements are determined by state law, the requirements vary a lot across the country, but generally most jurisdictions use some combination of these three types of disease reporting categories to create their disease reporting lists. Okay, so now we're going to talk a little bit more about disease investigation. So once a condition is reported, the health department must then investigate the reported disease. Most states and territories require by law that the state or local health department conduct some sort of investigation upon receiving a report. The investigating body may interview healthcare providers, patients, they might ask for laboratory samples. They often must access patients' medical records and other information to be able to investigate the report and its potential effect on the public's health. Investigators also often employ contact tracing to find everyone who came into contact with an infectious person and to watch for signs of illness in that group of people. These actions all require public health investigators to access a lot of information that is otherwise considered private health-related information. And these actions are all taken only under legal authority that's granted to the public health agencies in state statutes and regulations. And those laws also provide limitations on this authority in order to protect an individual's rights. And so that's what I'm going to spend most of the remainder of the time talking about, is the privacy protections, exceptions, and waivers. So when discussing limitations on the disease investigation authority, we're going to consider these three: privacy protections, exceptions to those privacy protections, and then waivers of the privacy rights. So many states have laws that sort of very broadly protect individuals' information by guaranteeing a right to privacy or by requiring the holders of that information to keep records confidential. These sort of generalized protections of individuals' information by default, even if they're not expressly stated as so, are going to include protections for public health information. For example, vital statistics or vital records. Those contain information about, life events such as birth, death, marriage, and disease. So obviously there's health information that's inherent in the circumstances leading to a person's birth, death, and, disease burden. So state vital records laws often protect the information within the record by limiting the information to be collected in the record at all, and by limiting the people or entities who are allowed to access the vital records information and the purposes for which that information can be released. I put up an example here from the Illinois Department of Public Health that the Department of Public Health limited access to all vital records so that only information may be released to public health agencies administering health, welfare, safety, law enforcement, and other public assistance programs when deemed in the public interest. Another example of a generalized law protecting individuals' information is public access laws. These laws are also often known as freedom of information laws, open records laws, sunshine laws, but they all aim to promote government transparency by guaranteeing public access to public agency records. So public access laws typically allow citizens to request public records from any state or local department, agency, board, and other government entities, which includes health and public health organizations. But these public access laws do provide exceptions to these required government disclosures when there's a significant privacy interest at stake, or when other federal, state, or local laws require that the information be kept confidential. And the information that's protected by this kind of exception will often include physical and mental health records, diagnoses, and treatment notes. So I've got an example from Hawaii here. Hawaii's Uniform Information Practices Act requires state and local units of government to make records available, but provides an exception to this disclosure when the disclosure would constitute a clearly unwarranted invasion of personal privacy, and includes information relating to medical, psychiatric, and psychological history, diagnosis, condition, treatment, evaluation, etc. And then finally, many, if not all, jurisdictions have laws requiring healthcare providers and facilities specifically to maintain confidentiality of health information collected from individuals seeking care for physical, mental, and behavioral health. In addition to HIPAA, healthcare providers and facilities may be required to develop a medical records retention policy, and access to medical records may be limited by statute or regulation. And these laws may apply even when laws like HIPAA do not apply. So for example, Montana's Uniform Health Care Information Act expressly aims to fill gaps in the medical records protections when the HIPAA privacy rule might not apply. So Montana's statute that I've put up as an example says that a healthcare provider may not disclose an individual's health information to any other person without the patient's written authorization. Like the HIPAA privacy rule, however, the Montana law provides several exceptions to the patient authorization requirement that impacts how an individual's health information is shared with the public health field. So a healthcare provider in Montana may disclose health information for the patient's care, for IRB-approved research, and for use by federal, state, and local public health authorities for activities aimed at protecting the public's health. So many of the privacy and confidentiality laws that Kaysen and I have been talking about provide exceptions for public health activities specifically, when otherwise the information must be kept confidential. And this applies generally to actions taken under the umbrella of the health department or the public health agency's authority. Federal reporting requirements that are tied to funding, for example, is an exception to privacy, often an exception to privacy protections. State law requirements mandate that certain health information be sent to a public health agency, such as, like I mentioned earlier, confirmed and suspected diagnoses of reportable diseases and conditions. State laws may also authorize a public health agency to seek out and collect health information as part of a disease investigation and control activity. Or in an attempt to access contacts of an individual as part of contact tracing. State laws also authorize public health agencies to obtain health information as part of their surveillance activities or public health registries, such as cancer registries and immunization information systems. So in addition to public health activities, providing investigators with an exception to many state privacy laws, there are laws that govern the use and release of health information, specifically held by the jurisdiction's public health agency, regardless of the source of the information or the purpose of collecting the data. And those laws will determine when use and release may be done by the public health authority without authorization. So these laws are going to govern how the agency holds the information and determine the purposes for which the agency may release the health information to outside partners. For example, Massachusetts Department of Public Health regulations prohibit disclosures of health information held by the department and outlines express purposes for which an exception exists, which includes disease investigation, control, treatment, and prevention purposes. And here's an example from Maryland of a state privacy law dictating confidentiality of data that's reported for public health purposes specifically. I won't read the whole law to you. I've sort of highlighted the important pieces. And it's important to note that in this example, a public official refers to more than just the public health officials. And that's not the case in all states. Here's an example from Pennsylvania, dictating confidentiality of data reported for public health purposes, again, that requires that case reports submitted to the health department be kept confidential. and then lists a couple of exceptions for which release of that information is allowed. And then one more from Utah, which is important to highlight because it includes an enforcement provision that's not actually present in many states' disease reporting requirements, that breaching the confidentiality requirements will result in a Class B misdemeanor. Okay, so we've kind of already been talking about exceptions to privacy protections, but many of the laws that we've been talking about, both federal and state, provide specific exceptions, again, for public health activities. Exceptions to privacy protections can serve the public health interests. Privacy interests receive extensive protections, also, and that's why we have laws like HIPAA. Sharing information is at times essential for protecting public health and well-being, but we also have to always balance that with protecting the rights of the individual. So these sort of privacy protections for the individual include notices that are given to an individual when the government wants to collect private information. These notices enable people to make informed decisions about whether to give information about themselves to the government, and also they tell when information must be provided. So this is an example in Minnesota of the Tennyson warning. So states may have requirements to provide privacy notices. Oh, sorry, I didn't click it. Here we go. So when the government entity is collecting data about an individual, notice must be provided, and that notice must include all of these items listed below: the reason for collecting the data, how the data will be used, whether the person is legally required to provide the data, consequences if the person provides the data, consequences if they do not provide the data, and also the identities of people and entities that will be accessing the data. So this warning doesn't prohibit investigations, it just provides notice that must be given during investigations. State notice requirements like this can be complex, especially when there are federal personnel involved in collecting data that is bound for, the Minnesota government entity specifically. And that is the end of my presentation. I'm going to turn it back over to Kaysen. My contact information is here, and I'm available for questions at the end.
All right, thank you, Rachel. I thought we'd take a bit of a change in gears here, because we've been talking a lot about what can be done with data, but what can be done is sometimes not the question that is ultimately acting as a barrier to a certain a proposed data use activity. The question that most often serves as a barrier to whether or not you can use or disclose information is a question about what should be done. And those aren't parallel or are not complementary. Sometimes there's a conflict. Not just because something is legal doesn't mean it's ethical. Just because something is ethical does not mean that it's legal. So during this brief section, I want to explore about how ethics are used to identify and resolve dilemmas about what should be done. I also want to compare and contrast bioethics, which if you're in this space a lot, chances are that that is your predominant, or it is the predominant way of thinking about ethical issues in this space at the moment. And I'm going to contrast that with public health ethics, which is a relatively new field in the last couple of decades, and it fits a lot of these types of situations in a much better way, much more complete way than bioethics does. And I'm also going to explore very briefly the new WHO guidelines to ethical issues in public health surveillance. This is just an incredible tool to resolve many of these what seem like intractable ethical issues that get in the way of decisions about whether or not to share or not to share. So a lot of times when I talk about ethics, I like to start from a very, very beginning about how ethics really frame the decision-making behind what should be done. And what I like to do when I'm talking about this is go to the MIT moral machine. And this was an online platform, and they were trying to explore this concept of what should we program autonomous vehicles to do in essentially lose-lose situations, right? Where there are very serious consequences if you turn left, serious consequences if you turn right. Because we have to program these self-driving cars to do one or the other. So what should we do in these situations? And so what the moral machine does is it gives you situations like this. We've got a car, it's an autonomous vehicle, it's barreling down the road, and it's headed right for a barrier. And if it hits that barrier, the chances are that the passenger within that autonomous vehicle will surely perish. Or we can program this autonomous vehicle in this situation to swerve to avoid the barrier, but guess what? If we swerve to avoid this barrier, the car is going to run into a pregnant woman, two babies in strollers, and right there at the bottom, a very small kitten. And so you are forced to choose what should this autonomous vehicle do in this situation? What is the right thing for it to do? And so I actually want to pause for a second and give you this question. What should the autonomous vehicle do? The option on the left, barreling straight ahead where the passenger is surely going to die, or to swerve to avoid the barrier, but in doing so, killing this pregnant woman, two babies, and a cute little kitten. So take a couple of minutes and think about what you think the autonomous vehicle could do. Okay, so how did you decide? Well, there are a number of different ways that you could have decided what the autonomous vehicle should do in this situation. Many of you, I'm guessing, looked at the comparative numbers or the impact of this decision and maybe decided that, you know what, we want to save the most lives in this situation. So we are going to instead, allow the autonomous vehicle to smash into this barrier because more lives will be saved that way. And that's an example of using type of a utilitarian ethics framework to make this decision about what should be done. What is going to do the most good is what a utilitarian framework would ask. Alternatively, you could have been very concerned about the passenger. If autonomous vehicles are going to succeed and arguably, reduce all these public health problems related to automobile accidents, then we need to be able to trust the autonomous vehicle to take care of the passengers, right? We need to, and in a certain sense, you might see there being a duty on behalf of the car to protect the passengers, the duty on behalf of the car manufacturers to protect the passengers. And so you might say that, the right thing to do here is to honor this duty, this relationship between the car and the individual who is putting themselves at the mercy of this car. Alternatively, you might have noticed that these individuals crossing the street are breaking the law, that they are crossing against the crosswalk, they are jaywalking, and shame on them. And you might have said, you know what, in this society, we want to promote certain virtuous behaviors or activities. And so we're going to promote those activities, not because they're inherently good or inherently not evil, but because we think that they are something that, as a society, we should promote. So this is a somewhat extreme example of application of a virtue-based ethics. But the point of this slide is there are lots of different ways that you might go about deciding what is the ethical thing, what should be done in this situation. And not all of them are going to be right or wrong. The question is finding a framework that is appropriate to apply in a given situation to help you come to that decision. So let's take this example of the car and deciding, and look at some data examples. So in my research, I talk to a lot of patients, and I'm seeking, what their perspectives are and what their preferences are and attitudes are related to how data is used and reused for various purposes. And I get a lot of feedback from these patients, and they like their data being used for research, but you know what? They really want consent. They want the researchers to go back to them and get another consent if they're going to reuse that data for a different research project. And then, we ask them again, what sort of things do they want to be done in terms of protecting their data? And they all say, you know what, we really want this data to be de-identified. We want all of our identifiers to be, scrubbed out so that we're protected in case this data is accidentally let out there. But the problem is that these are incompatible requests. If I de-identify data, then there's no way for me to go back and provide them an opportunity to consent or not consent. And so these are two different ways that you might think about protecting the individual. On one hand, we can protect them by scrubbing their identifiers. On the other hand, we can protect them by giving them a right to decide whether or not their data is reused for different purposes. And again, these are in conflict. These two different methods are in conflict. No doubt you have come across a situation where you've been forced to think about, right, should we enforce very strict privacy rights for all individuals? Or should we allow some limited benefit or some limited data use for public benefit, right? This idea of the individual rights versus the collective benefit. And these issues are again, in fairly frequent conflict. And how you answer the question about what should be done depends a lot about the specific ethical framework that is most appropriate for that situation. So let's talk about two ethical frameworks here. Bioethics, which is most frequently used in situations of research ethics and in situations where we've got in healthcare situations. And then public health ethics, which I'll talk a little bit more about later. But before we dive into bioethics, you always have to consider the history and the context in which they were born. And it's a history of scandal and tragedy, where there were these horrific events, the Nazi war experiments, the Tuskegee syphilis study, where there are researchers and there are physicians that are doing things that they are arguing are for the common good, but they are putting the participants in just extraordinary danger and harm. And so it's within this context of scandal and tragedy that bioethics come to be and come into their own. And when we talk about bioethics, most often we're talking about 3 ethical principles laid out within the Belmont Report. Respect for persons, or treating individuals as autonomous agents. And this is the ethical principle that is most implicating or most relevant to the issues of informed consent. It's like we are respecting the individuals, we are respecting their autonomy by giving the opportunity to decide whether or not to participate. Beneficence, do no harm, idea about maximizing benefits and minimizing harms. And justice, who ought to receive the benefits of research and who ought to bear the burdens of research. And interestingly, if you go back to the words of the Belmont Report, as they're laying out these ethical principles, the focus is on the individual patient, the individual research subject. So when we're talking about beneficence, we're talking about doing no harm to those individuals. We're talking about maximizing the benefits to those individuals and minimizing harms to those individuals. We're talking about justice. We're talking about how justice applies to the individuals that are being subjected to the research. It's very individually focused. And to a certain extent, that makes a huge, it makes perfect sense given the context of bioethics, where the Nazis and the people running the studies like the Tuskegee syphilis study were using arguments of common good. And in some ways, the reports like the Belmont Report and the Nuremberg reports, they were rejecting this and saying that, it's the individual in these research and medical contexts that is most important. But as we've progressed and as we continue to work with bioethics over time, there's come this broad recognition that it's a really awkward framework to apply to public health activities. And one of the principal reasons for this is that public health isn't designed to protect individuals. Public health is designed to protect entire communities. Its whole purpose of existence is to protect and promote health within populations. And so it's a very, very awkward framework to apply. And I would argue that's one of the reasons why we see a lot of barriers or ethical issues being cited as barriers to the public health use of data, is because we're stuck in this bioethical way of thinking. Well, one of the great, I think, documents in public health ethics is the recent WHO guidelines on ethical issues in public health surveillance. And I think this is probably the single greatest takeaway of this segment of the webinar, is that these guidelines serve as a tremendous tool for not only identifying ethical issues relating to the public health use of data, but understanding how those ethical issues resolve in a public health context. Because, the WHO guidelines, they use 4 principles, similar, one extra than the bioethical framework, but in a similar way. Those are common good, right? Equity, respect for persons. Notice this is a shared ethical principle with bioethics. Just because the primary objective of public health is for common benefit, that doesn't mean that we can overlook the rights and interests of individuals. And good governance. And so recognize that, especially since we've got respect for persons and common good, that there are going to be some conflicts that need to be resolved, where sometimes these are some competing principles that need to be explored in greater detail. The thing that really helps or really makes public health ethics a useful framework to proceed is the fourth principle there, good governance. That if you've got adequate mechanisms for accountability, transparency, and community engagement, then you still have a way for the public to look at critically the trade-offs between common good and respect for persons. And you give them a mechanism to do something about that, to demand for action, demand to have the activity done in a different way. But good governance is really the glue that makes the public health ethical framework really work well. Now, the WHO guidelines don't stop here. This is what bioethics does. They give you these three principles and say, okay, figure it out. The WHO guidelines go a step further. They say, here are these four principles, and here's how they apply in specific situations. And so I'm going to go over just a few of these guidelines to give you an idea about what they look like and the types of things that they say. But I would really encourage you to take a look at these WHO guidelines. If you are if your organization is constantly dealing with these questions about what should be done, I think they're going to be an awesome tool to help you not only identify, but work through some of those issues. So guideline one, countries have an obligation to develop appropriate, feasible, sustainable public health systems, right? So this is an obligation to conduct public health service, right? To do this activity is in fact an ethical obligation. Guideline 11, that under certain circumstances, and those circumstances are described in a little bit greater detail in the guidelines themselves, but collection of names and identifiable data is ethically justified, right? Guideline 12, right, that under certain circumstances, and again, there's discussion in the guidelines about what those circumstances are, informed consent isn't always ethically required, right? And so again, they help you work through these conflicts that constantly come up in ethics. Guideline 14, right, that there is an obligation to share public health data with other public health agencies as long as there are appropriate safeguards and justifications. Guideline 15, during a public health emergencies, it's imperative that all parties involved in surveillance share data in a timely fashion, right? So again, these are very, very useful guidelines to not only identify issues, but see how they resolve in certain public health contexts. And chances are, I think you'll find it a somewhat liberating document when addressing some of these ethical issues that you might be experiencing in your professional experience. Big ideas, these ethical frameworks guide decision making. And often the most difficult question is figuring out which ethical framework is the most appropriate one for a given situation. And really the big takeaway from this small segment of this webinar is that these WHO guidelines are very, very, very helpful when dealing with difficult data use issues in a public health context. And I believe that is all I've got for you. There's my email address. Feel free to reach out. I'd love chatting.
All right. Thank you so much, Kason. I really appreciate that. That was a fantastic couple of presentations, and thank you so much to Rachel for your wonderful presentation. As promised, we've got a half hour for question and answer, and we've got a lot of really good questions already queued up. So I would like to encourage anyone else, if you have questions, please type them into the Q&A box. We'll get to your question hopefully in turn. Your questions that you type in won't be viewable by others. So if you're feeling a little embarrassed about a question, don't worry about it. No one's going to know who sent you the question, even me. So please go ahead and shoot us a question. And the one that I will dispense with right now was the most recent one, which is, are the slides available? The slides will be available on I think www. It's on nga.org/webinars. That's where the slides will be, as well as the recording of the webinar is going to be posted there. So that's nga.org/webinars. All right. So our first question, could Professor Schmidt please clarify whether a local public health department that provides healthcare and transmits health information electronically in connection with a HIPAA transaction is a covered entity or hybrid entity, and also a public health authority for purposes of obtaining access to protected health information from other covered entities?
Sure, I'm happy to answer this. I think this is a really terrific question because on one hand, there's this wonderful public health set of exceptions within HIPAA that allow these uses and disclosures of health information. But on the other hand, you've got these public health authorities that are sometimes doing things that make them covered entities. And you know, what do they do in this situation? Fortunately, the regulations are, if I understand the question, are fairly specific on this point. And the specific citation, and I'll throw this in the chat window, but is 45 CFR section 164.512 B2. And the subsection B is the public health exception or set of exceptions to the HIPAA privacy rule. And the second part of it says, if the covered entity is also a public health authority, then the covered entity is permitted to use protected health information in all cases in which it's permitted to disclose such information for public health activities under this provision. So if you got a health authority and it's also a covered entity, that public health exception applies to it, allows it to both use data for those purposes and disclose data for those purposes. So I think that's I think that answers the question. And if not, I can happy to see if I can help further.
No, I think that was great, Kason. Rachel, there's a question about commenting on how states can or do require reporting of drug intoxications or poisonings, especially opioid overdoses. And in case if you have anything else to share on this, please feel free.
Yeah, so when it comes to reporting overdoses, states have been pretty slow to add any sort of requirement reporting non-fatal overdoses. If it's a fatal overdose, then you get into death reporting in coroners and sort of a separate, you know, when it becomes a death, that's a separate sort of reporting requirement related to vital statistics. But when we're talking about non-fatal overdoses, there aren't really a ton of states that require it. I do know that Wisconsin has a law that requires law enforcement officials to report identifying information regarding non-fatal overdoses to the state's PDMP, the Prescription Drug Monitoring Program. And I think West Virginia has a similar policy. They have a requirement to report to the Office of Drug Control Policy. So there are a couple of states that have reporting requirements specific to non-fatal overdoses, but it's really not very widespread.
Thanks. And Kason, anything to add on that?
Yeah, I would just add that, you know, sometimes with overdoses, you may have a situation where the federal rules protecting substance abuse treatment records might prevent some reporting. Now, those are limited to programs that are regulated under that act, but this is the Part 2 regulations, and they are much more strict than HIPAA is in terms of what is permitted to be disclosed. And unlike HIPAA, they do not have a public health exception. So, that is one reason why some of these records, if they are covered by Part 2 as substance abuse treatment records, there may be some barriers, legal barriers to sharing that information for that purpose.
Thank you so much. So to Rachel, are federal entities such as VA hospitals or military bases required to comply with state laws that require reports or other information sharing with state or local public health officials?
Yeah, that's actually a question that I get a whole lot, and generally the answer is no. Federal entities are not required to comply with state reporting laws like disease reporting, but some just do it voluntarily. The VA put out a directive a couple of years ago and recently updated it to make it more comprehensive, but the VA directive said that they basically are voluntarily choosing to comply with disease reporting requirements by voluntarily reporting infectious disease occurrences at VA facilities to state and local health departments. So I know that some federal agencies are voluntarily choosing to do so, but none, as far as I know, are required to do it.
And any thoughts on military bases?
No, we got that question recently also, and didn't find anything specific.
Yeah, it
Do
sounded
you
like,
remember what we were? Yeah.
yeah, the thing, what most folks said, we got a question from a state health department attorney on this issue, and we kind of pitched out to a group, a listserv we have of health department attorneys at the state level to see if anyone had dealt with a similar issue, and it seems to be a base by base basis, where the health officials responsible for collecting health information and doing, investigations if there's a case of food poisoning on the base and things like that. They determine at their own discretion whether or not they're going to share that information with the health department. And some states have had success with getting blanket agreements from those bases that, yep, we're going to comply, we're going to follow the disease reporting requirements for the state as if we were a healthcare entity, and others are, we'll share information with you as we see necessary. Okay, next question. Does HIPAA apply to information that is given voluntarily for emergency planning purposes? I'll see, Kason, do you want to take a first stab, and Rachel, you can add if you have anything to share?
Yeah, so the first question is whether or not HIPAA applies, if you're talking about a covered entity that is receiving individually identifiable health information, then HIPAA will apply. The question is then whether or not the specific use falls under HIPAA's exceptions. So as long as the individually identifiable health information is given to a covered entity, then HIPAA will apply. The next question is whether or not there is an exception that permits the data to be used for those purposes. Based upon the general description, preparedness, there's probably a good argument for that, but it might depend on the specific factual context to know for sure. But yeah, as long as it's a covered entity, as long as they're receiving that individually identifiable information pertaining to health, then HIPAA will apply. And the next question is whether or not the various provisions or exceptions would allow that use.
Always talk to your lawyer. Rachel, anything to add on that?
Nope, that's what I would have said too.
Awesome. All right. So the next question for both of you, we'll give Rachel, you can start us off. Do you know of any model guidelines available for information sharing between public health entities?
I think, I want to say, is it ASTO, the Association of State and Territorial Health Officials? I believe they have some guidelines or a toolkit related to sort of a lessons learned from, I think, all the way back to the, well, I'm blanking on the public health emergency, the contaminated epidurals. But I believe that ASTO has that toolkit on its website, and that talks about data sharing in sort of that emergency context.
And I just pulled it up. I'm going to send it out in the chat box to all the attendees. And anything else?
And that is, I think, that's my go-to.
Kaysen, any resources to share?
No, I think that's probably the best specific resource related to that.
Wonderful. Thank you. All right. I'm going to pitch this to both of you. Feel free to, give I'm not super familiar with this topic because I know it's a very federal question. If we had maybe some CDC Office of General Counsel attorneys on, they might be able to answer this more specifically, or I could be wrong. You guys might knock it out of the park. How does the Privacy Act factor into public health emergencies?
Cool. Kaysen, you got anything?
I'm digging deep here too. So the Privacy Act generally protects, and my terminology is going to be off here because I'm a little bit rusty on the Privacy Act, but it involves record sets containing identifiable information. And the thing with the Privacy Act is that many federal agencies have the authority to promulgate rules and regulations that apply the Privacy Act to the records that they have, the protected records that they have. And so even though the Privacy Act is meant to be this umbrella, law, there's quite a lot of variation about how it applies to each federal agency. And, it goes beyond just, how the federal agencies are applying the Privacy Act. In many cases, federal agencies are allowed to provide provide their specific rules to specific data sets that would otherwise be covered by the Privacy Act. So, the protections really do vary wildly. The interesting thing is, and if you're thinking about a very specific data set, you can, the agencies that are covered by the Privacy Act are required to put notices about this data sets that apply the Privacy Act or the data sets that don't apply the Privacy Act. And one of the things that the Privacy Act does permit is uses or routine uses of protected information. And as you might imagine, based on everything I said, that the federal agencies have the authority to define what routine uses are permitted under the Privacy Act. And if my memory serves me correct, there are many data sets within HHS that do in fact permit uses for public health purposes. But again, this is really something you're going to want to talk with your lawyer. There's just an incredible amount of variation in how it applies within the federal government.
Great, thank you, Kaysen. And actually, our next question I think is informed by your answer. And I'm gonna take a stab just based on the things that I have picked up doing preparedness legal work around the agency. The question is, when CDC receives a HIPAA data set from a state health department via data use agreements, will HIPAA protection be carried over to CDC? And my understanding, in case you correct me if I'm wrong, is that HIPAA's, CDC is receiving information as a public health entity, not as a covered entity, because CDC doesn't provide any covered services. So the receipt of that information that CDC gets falls not under HIPAA, but under the Privacy Act, and it's actually the data use agreements that the person who asked the question references that applies to what limitations there are on what can and cannot be done with that information. Kaysen or Rachel, is that an accurate summation? Anything to add on that?
Yeah, I think that's accurate from my end.
Yep, sounds good.
All right, it sounded accurate. Appreciate that. Again, those kinds of things, certainly the CDC Office of General Counsel are the best folks to talk to about that. And if you have any questions, please feel free to reach out to us. We have lots of friends over at OGC that can help provide information, especially if the person who asked the question is a CDC employee, then they certainly would love to answer your legal questions. All right. So another question is, how does de-identification work in a practical manner? Is coding of data without providing access to the key considered to be de-identified? Who wants to take that first? Kaysen, Rachel?
So, you know, I would go back to the definition of identifiable data under HIPAA. And, you know, it's information that identifies the individual or with respect to which there's a reasonable basis to believe that the information can be used to identify the individual. Now, if it was once identifiable and you are attempting to make it legally de-identified, there are two ways to do that. One is called the HIPAA safe harbor provision, and that's where you have to strip 18 categories of identifiers from the data set. So if you wanted to legally de-identify it pursuant to the safe harbor provision, then just hiding, you know, the names or health record numbers from that data set wouldn't work with that that method to legally de-identify the data. The other method is the expert determination route. So if you have somebody who is an expert based on their training and their expertise, is trained in statistical methods, then they can, you know, apply those statistical methods to the data set and make a determination that the risk of identifying an individual is quote, very small. And if it's very small, then, and this person has made this determination, then the data set would become legally de-identified. So in that circumstance, you might have an expert who takes a look at, you know, what you've done in terms of coding, and, you know, said that, you know what, the risk of identifying an individual based upon what you've coded here is very small. Stamp. Here's my determination that it's de-identified. Then that might fly. But chances are, simply coding the information that was previously protected health information in this way will probably not fit under either one of those two legal methods of of de-identifying data. There are various ways that you can, in practice, de-identify data. You can chafe data. You can throw a bunch of noise in the data set that make it difficult for individuals to re-identify. There's statistical methods called, differential privacy, where, to a certain sense, you're introducing some random variation that in the individual records that does not affect the aggregate observations that you might want to make. There are a whole bunch of different ways that you can do it. You can also, strip various types of identifiers that reduce the chance of identifiability. But that might have been too much detail, but hopefully I answered your question.
And I was just going to add that the HHS website has a lot of good sort of Q&A style guidance for professionals and also individuals. I sent Greg a link that I think he was going to share with the panelists. Yep, there it is. That might also be helpful. It's the word version of what Kaysen just said about the two de-identifying methods.
Yep, just shout it out to all the folks, all the attendees. So, Kaysen, this might be stretching your knowledge on part two. So feel free to say, we'll look more into this. But the question on part two of the federal regulations and the fact that there is no public health exception, does that apply to deceased individuals? Can a medical examiner obtain those records that are relevant to cause and manner of death?
Well, so the 42 CFR Part 2 regulations, which govern substance abuse treatment records, right? They cover two federally assisted programs that hold themselves out as providing substance abuse diagnosis, treatments, or referrals. So those rules apply to these people that are holding themselves out as offering these types of services. If the question is how does this apply to a medical examiner and those death records, chances are that the medical examiner, the coroner, is not holding themselves out as providing substance abuse treatment, diagnosis, or referral services. So they may or may not be getting federal assistance. So I would be very skeptical that a coroner or medical examiner that is, creating records on related to overdose deaths would actually be covered by the 42 CFR Part 2 regulations.
Great, thank you so much, Kaysen. We are getting close to the end, but we have so many really great questions. I love this next one. This is such a great question. So for both Kaysen and Rachel, maybe we'll give it to you first. Do you have any comments or thoughts or concerns on the shifting boundaries of surveillance and the functions that may be outsourced? We hear about a lot of different public health services being outsourced to contractors or outside organizations. Have you observed, received any questions related to these? Have any thoughts on this topic?
Oh, go ahead, Kaysen.
No, please, Rachel.
Well, I was just going to say that the questions or concerns that I'm hearing are more on the side of the shifting boundaries of identifiable information and how much easier it is to re-identify information, based on the data that comes from my smartwatch or what I say about my health on Facebook, as well as the usual health information sources. So I think the boundaries of surveillance are shifting in that way, in that there are new considerations to think about when trying to protect health information. Kaysen, do you want to add?
Sure. So You know, I retreat all the way to, you know, the basics of surveillance, and particularly public health surveillance. And, you know, the basics are, you know, you go out, you collect data, you analyze that data, you disseminate that data, and then you act on that data for the benefit of the population. So, you know, you're collecting this data, you're disseminating it, and you're acting on it for the benefit of the population. And so there's transparency, and there's the public benefit are within the very bones of what public health surveillance should be. And so to the extent that you're outsourcing functions of public health surveillance to different contractors, you can never lose sight of the fact that it's the people that you're serving that are important. It's not surveillance isn't justified just collecting and learning from information. It's got to be given back to the people in a way that's meaningful for them. And in terms of the, you know, if I were to look at this from a public health ethics perspective, one, you've got to involve the public in the decision-making process, right? There have to be mechanisms for transparency and accountability. So what happens if there's a misuse of data and it's in one of these outsourced contractors' hands at this point? There's got to be a way to hold that entity accountable to the public, right? And if you're not involving the public in these decision-making processes, then you're really undercutting the ethical foundation of these types of activities. So first and foremost, you got to think that you are doing this on behalf of the people, and you know, so it's an awesome responsibility on behalf of public health officials everywhere.
Thank you so much, Kason. That was, and Rachel, those were really great answers. And to speak directly to the questions of you know, outsourcing public health services in its relationship to HIPAA, and I'm not speaking on any state privacy laws. They would, you know, certainly apply, and it's something to be considered. But just thinking about HIPAA in isolation, the question that we got a lot during the Zika response was, okay, you've got a health department and they fall under the public health exception because they're a public health authority. But what happens when that health department is in contracting with a mosquito abatement company to spray near a home where someone was infected with the Zika virus? Does that public health exception that the health department you know, has extend to their contractors? And the thing that we found, and we wanted to make sure we provided to folks clarity on, is that yes, it does. The public health exception applies to the health authority and contractors, agents of that health authority. So when we think about outsourcing functions, that's another good thing to be aware of. Well, you know, we only have a minute left. Oh my God, no, 8 seconds left actually. So I don't want to take up people's time too much. I just really wanted to thank our distinguished panel. This is the conclusion of our webinar. All of the panelists who shared information with us were absolutely interesting, riveting information. Your contributions have been so valuable to everyone who joined today. This concludes what has been a fantastic webinar series in partnership between CDC Center for Preparedness and Response and the Public Health Law Program, the National Governors Association, and the American Bar Association. We really appreciate all the time and energy from all the staff from all organizations and all the time and energy you put into making sure these webinars were a success. Really special thanks to all who attended these webinars, this one and the past 3 webinars. Thank you all. You're what make webinars possible. People who listen to us drone on about these legal issues. So if you would like to re-listen to the information or you missed any of the previous webinars, recordings are all posted at nga.org/webinars, as in the National Governors Association, nga.org/webinars. Thank you all so much for joining us today.